where other places where other older people like to live, for example, such as in their homes and in their communities for as long as possible. So I've got through a few things. I want to us to appreciate how the pandemic and our experiences have influenced our views on what long-term care might need to look like across Canada. I want us to appreciate how aging in the right place needs to begin with the development of age and dementia-friendly communities. I then want to provide us with some insights that can enable meaningful community-based systems change that promotes more integrated care and support for all Canadians as we age as well. So first of all, when we start thinking about how best to integrate care and support for older persons, start realizing that there are a number of barriers that actually come into play here. And this has been a challenging, long-standing challenge. In fact, I wrote this slide over a decade ago, for example, and I really haven't had to change it much because we still have some fundamental issues that we haven't really adequately addressed, but these are barriers that we need to really address if we want to get serious about supporting people to age in the right place. Because first of all, we don't really do much to empower older persons, families, and caregivers with the information they need to navigate the system. So often a lot of people don't have a lot of experience with navigating the long-term care system or the need for home and community care services and other issues. And so this often becomes problematic when people just need to start looking for supports. They don't even know what's available out there, and they're not even sure where to start looking and how to ask for them as well. And so that's a challenge. We also don't require the majority of any of current or future health and social care professionals to learn about caring for older people. And so often when you look at medical school curriculums, when you look at school of nursing, PSW, social work curriculums, there's not really a focus on older people per se. And issues like dementia or other things that are more common in older populations. And so when people don't appreciate these issues, it's hard for them to adequately be able to support older people who might be struggling with often interrelated health and social care needs. We often don't really do a good job of talking to each other within and between sectors and professions well. So for example, I'm covering 3 hospitals at the moment in downtown Toronto, and I had a community social worker that I work with quite closely who calls into our rounds because we try and keep things connected. And she was saying, one of our patients got admitted into your hospital, and I left my information for the social worker in the hospital to call me back, but they haven't called me. And I don't even know where this patient is or what's going on with them. And I said, oh, that's curious. So then this morning I basically, spent time kind of making sure that the social worker in the community was connected with the social worker on the service, on the inpatient service. That way, again, there could be really key communication because this patient that that this social worker is advocating around has dementia, is trying to stay at home and independent, but really needs a lot of good coordination to occur between hospital and the community to make sure that this is going to be a safe discharge, and this is going to be a discharge that's going to really work well, to make sure there are no gaps in care. But again, it was one of those things where if I wasn't there to kind of facilitate things, then we would have really had a gap in care that could have persisted longer than it needed to. And this is a challenge because we often work in silos. We don't work as a system. And then the other challenge is that we often plan for today and not for tomorrow with regard to understand the mix of services that we should invest in to support system sustainability. And this is a challenge because often we wait for something to become a political scandal or an issue like the state of long-term care in Canada before we start actually saying, okay, well, maybe we should put more money into the system and maybe we should do more. Or we're realizing that people really want to stay at home, so maybe we should invest more in home care, as opposed to really thinking about our aging demographics, which are really well laid out and well known for the next 10, 20, 30 years, and what are the things we fundamentally need to do to better align our systems and plan for the population ahead of us that is aging. So we know that our experiences often shape our perspectives, for example, and for many older Canadians, accessing long-term care usually means having to leave one's own home or community. And when you leave your community and you have to be institutionalized, and you're often not able to receive culturally safe and appropriate care close to your family members and friends, it can be an unfortunate reality for many people. And we know that right now there exists a universal desire to age in place amongst most older Canadians. And so the question is, how can one enable this across Canada? So we also know that the pandemic itself has shaped our perspectives, because we now know that nearly 100% of older Canadians want to age safely and independently in their own homes for as long as possible. It wasn't always this definitive prior to the pandemic, but certainly now the pandemic has shaped it in the minds of many people that they're not really interested in moving into a long-term care home. They rather stay in their own homes as long as possible. We also know that 60% of Canadians and almost 70% of Canadians 65 and older have reported that the pandemic itself has changed their opinion of whether or not they'd arrange for themselves or an older loved one to live in a nursing or retirement home. So we also know that 57% of Ontarians don't believe that they'll have access to good quality long-term care when they need it. And I would say if you did the same poll in Saskatchewan, you might find the same rating amongst people in that province as well. So we also realize that our realities have to be respected. And when you think about provinces like Saskatchewan or Ontario, big geographical land masses where there are people who are living in rural and remote communities and large urban centers, we know that small remote populations often do not support services and healthcare economies of scale. So people say, oh, we should build a long-term care home in every single community, but often you need to have the staff to be able to staff a home. You need to also have physical site and enough people being able to be in that home to actually make it economically viable. So this is where, again, the current traditional model of building large, long-term care homes might work well in an urban setting where there's enough people to support a home, but that may not work well in a small rural and remote population. And this is the thing, as long as we look at rural problems with urban solutions, we're going to miss the opportunities that exist to develop supports and services that allow people to age in place. And we have to recognize that communities often have an incredible amount of infrastructure, buildings, systems, roles, and individuals that can be activated to create meaningful systems change. So how do we think about that? And how do we think about the assets that we have and how they can be leveraged in different ways to better support people? So when we start thinking about how do we enable the future provision of long-term care in Canada and the future costs of care, I want to reorient you just so that you're familiar with where some of this work all stems from. And so years ago, I worked to create what we call a national senior strategy. And this was an evidence-informed strategy that was funded by the Canadian Institutes of Health Research, and really kind of saying, okay, this is what Canadians say they value. They value in being independent, productive, and engaged citizens. They want to lead healthy and active lives. They want to receive care closer to their homes or in their homes for as long as possible. And we need to respect and remember that there are many people who are providing care as unpaid caregivers, for example. So how do we better recognize and support them, for example? So we have to remember that these are key pillars of activities, and really we need to think about that as part of a broader national senior strategy. So when we think about long-term care, sometimes people think about, oh, that means care in nursing homes. But if you look around the world, if you look at Europe and other countries, including the United States, we use a much more broader definition to refer to long-term care. And really it's kind of think about it as people who need care over the long term. That's kind of as simple as that. But you start thinking about the types of care that people might need. And that might be care with what we call ADLs. Those are your basic activities of daily living. That might be bathing, walking, dressing, toileting, transferring, and eating. And IADL supports are those higher order tasks like preparing a meal, arranging transportation. It may be taking one's medications, paying one's bills, those sorts of things that are what we call your higher order instrumental activities of daily living. And often, if people can't do these themselves on their own, this might be provided by family members and friends or other unpaid caregivers, or it might be provided by a paid care provider. You might hire someone to do this for you, like if you hire someone to clean your house, or if you hire someone to provide you care, or if government-funded home care services might provide that support for a paid care provider to do that. When you think about where care can be provided, sometimes, we have to remember that there are people who are living in their own homes and communities who are absolutely nursing home eligible and receiving nursing home level care in their own homes, courtesy of their families, but also the home care system. And then there are people who are receiving care specifically in designated buildings, such as long-term care homes, for example. And then we think about, again, the types of care that I mentioned before, and the ways of thinking about approaches to care that could either be preventative or responsive. Responsive basically means that if a person needs to have a bath, then we're going to make sure that they can get support to have a bath. But preventative also means, or preventive means, also identifying opportunities that if a person may be suffering from some functional decline or at risk of having functional decline, maybe we look at an exercise and falls prevention program that can help them maintain their strength and independence, or even sometimes rehabilitate and regain that strength and independence that they may have recently lost. So this is where we think about preventative, but also responsive approaches to care, and care that's not only provided by primary care providers, but also maybe specialty care providers and other interprofessional people. So this is how other jurisdictions think about this, as opposed to kind of an either or situation. Either we support you in the community or we put you in a nursing home. It's better to think about these kind of things as needs and supports that people may need over time. So why does long-term care matter? Well, right now it's the largest form of hands-on care that's not covered under the Canada Health Act. And that's an issue because right now, when we created the Canada Health Act, or the forerunner to the Canada Health Act being the Medical Care Act of 1966, what we fundamentally know as Medicare, which is, as people in Saskatchewan, is something that started in your province, for example, then we realized that when you think about what Medicare fundamentally covered or was arranged to cover, it was about hospital and physician services. It wasn't about any other forms of care like long-term care, home and community care, or nursing home care. Now that care is being provided, it's publicly funded by the government of Saskatchewan, for example. But again, with the way that the coverage levels, the qualifying criteria, design standards, they vary significantly between Saskatchewan and Manitoba and Ontario and other provinces and territories. So it really is left up to each of the provinces and territories to figure out what they want to do, how they might want to do it, because it's not enshrined under the Canada Health Act as something that every province must be providing, and providing in a consistent, free, portable way, if you will. And we know that right now there's a growing value of these services to meet the long-term care needs of an aging population effectively and sustainably. So people are saying, wow, gosh, right now 1 in 5 Canadians happens to be an older person, but over the next 20, 30 years, we know that in the next 10 years alone, we're going to see many more older people. In fact, 1 in 4 Canadians will be an older person by 2031. And I would argue that Saskatchewan's an older province than, say, Alberta, where you might have less younger people staying in case they might be moving to Alberta or Ontario or BC, and so that you have the population that remaining tends to be older and therefore needing more support. Right now, the current demand for long-term care services as well is already unprecedented and is only expected to grow as the population ages as well. And right now, we know that our system has been plagued by longstanding systemic vulnerabilities when it comes to health human resources and physical design and redevelopment approaches. So we've seen that where there have been some issues that the government of Saskatchewan has tried to address in terms of who operates its own publicly funded long-term care homes, and also just the basic funding for its own long-term care system. You have provinces like British Columbia, Nova Scotia, Ontario that have all pledged now to move towards providing at least 4 hours of care a day. I don't know if Saskatchewan has also kind of thought about saying this is kind of what we want to be providing in our care homes. So we also know that when we look back, say, pre the pandemic, back to 2015, there was a survey that was done where 63% of respondents said that their family was not in a good position financially or otherwise to care for older family members if they needed long-term care, and it worried them greatly. That's concerning because, again, you would think that, okay, well, maybe we can just afford to buy the care that mom or dad needs. Well, maybe we're not in that position, and we might not even be in a position where there's enough family members who have the time and the ability to provide that care that mom or dad might need. We also know that right now, over 430,000 Canadians have unmet home care needs, and over 40,000 are on nursing home wait lists as well. So this is a challenge because, again, when you start thinking about, oh, why do we have so many people on our wait list? Well, we also know that when you can't get your needs met at home, then this is a problem. We know that about 1 in 3 older Canadians who's receiving government-funded home care is reporting that they have unmet home care needs. And so this is a real challenge when we think about the real gaps that exist in care, and what might actually be driving people to be on our nursing home wait list. In fact, CIHI has published various reports saying between 11 and 30% of people who are on nursing home wait lists and who are in our nursing homes often don't actually even need to be there. They could be supported in their own homes with existing home and community care services. So it really shows how a lack of one area really drives demand in another, and how this is problematic. So we also know that when we look at Canada as it relates to other countries around the world, we know that there's a specific differences in how we approach the provision of long-term care. So right now, for example, I'm going to show, if you can, hopefully the highlight works or the laser pointer works. This is a chart showing Canada versus other what we call OECD countries, or I like to call them the rich countries club. And this shows how, on average, the average OECD country spends about 1.7% of its GDP on providing long-term care services, for example. Canada tends to be below the international average at 1.2%, according to this chart from 2017. And over here, you can see countries like Denmark actually spend twice what the international average is. Go to the next slide. Well, we also know that when we look at, I think that might be the same slide. It is the same slide. So we spend far less on the provision of home community care overall. We also know that when you actually look at how we spend our dollars, we know that the average OECD country spends about a third of its dollars on providing care for people in their own homes, whereas Canada spends far less of its dollars on caring for people in their own homes, and the majority of its dollars on providing care for people in long-term care homes. And if you go to a country like Denmark, which spends twice what we spend of its GDP on long-term care services, you'll find Denmark spends 2/3 of its dollars on providing home and community care. Only a third of its spending goes towards providing care for people in long-term care homes. So a really different fundamental way of using its precious dollars. We also know that when you actually start looking at what the costs of long-term care will look like, the green represents spending on home and community care. The blue represents spending on nursing home care. And what you see right now is where we were at in 2019, just north of $20 billion, and where we'll be by 2050, just in responding to population demographics, that we'll actually be needing to spend over $70 billion 30 years from now to provide the same levels of care we're currently providing for our population. But that's if we specifically rely quite heavily on institutionalizing people as opposed to providing care for them in their own homes. And that purple dotted line at the very top, this actually represents what the income tax, proportion of income tax, both provincial and federal income taxes, will be to support older people. In fact, what you will see here is that that by 2050, 1 in every 5 income tax dollars would be going to providing just long-term care services, publicly funded long-term care services overall. And that's if we do nothing differently. So this is just saying this out loud in script, that basically we're going to see the amount of care being provided will go from 22 to $71 billion. So huge amount of spending that we'll need to meet the needs of our aging population. So we also know that between 2019 and 2050, there'll also be 30% fewer close family members available to provide unpaid care to a loved one. So if we're thinking, well, we can't afford to meet the needs of an aging population, so let's just lean more on family members and friends. Well, the challenges with declining birth rates, for example, and more social mobility, we're going to have fewer people having kids, and we're going to have fewer available family caregivers around. So the remaining group of family caregivers that will be around will have to increase their productivity by 40% to better meet the needs of an aging population. So how do we start thinking about the way we provide long-term care and how we can better support people to age in the right place? And this is a complicated chart that we've created that kind of really shows a pyramid, if you will, where we go from a hierarchy of needs. So at the base of the pyramid, we talk about people who are independent and well, and trying to stay independent in their communities. We talk about at the very top end about people who need to be in long-term care settings and what are the right models of care that need to actually be thought about in that way as well. And this is how we break it down. We talk about how in order to support people who are independent and healthy, we can look at various models of care, thinking about the idea of age-friendly communities, and thinking about property tax deferral programs that help people avoid some of the costs that might come, the increase in costs on property taxes while their incomes stay fixed, if you will. We think about home accessibility modification programs that allow people to age in their own place. There are neat models called home sharing or co-housing that people are experimenting with. There are life lease housing models and enhanced home support programs as well. We also think about how we can better define age-friendly communities. And really, we define these as communities that recognize, promote, respect, anticipate, and respond flexibly to aging-related needs and preferences as well. And this is the World Health Organization diagram that really shows you kind of what are the elements of an age-friendly community. And you'll see that only one aspect here is around health and community services. The other things that are important are the spaces and the buildings that we build, and the importance of services like transportation, housing, and thinking about how we better support communication and information, but also other key tenets that really support people to age friendly and well. When we think about how we basically support people with moderate needs, for example, there are ideas like these ideas of naturally occurring retirement communities, the idea of dementia-friendly communities, the transportation services, and other things that we can do to really support people to age in place. And there's really good evidence behind each of the things that I'm sharing with you today that we discuss extensively in that report that's available for free called Enabling the Future of Long-Term Care in Canada. And so it just gives you the evidence behind things that we can do. And if we start doing these things at the lower level and making sure they're in place, my goodness, you can support more people to age in the right place, age in their own homes and communities for as long as possible. And then I think when you start thinking further, we start thinking about what we can do to support people to stay in their own homes and communities with more specific programs that really support caregivers, provide home-based primary care, adult day programs, supportive housing models, and even nursing home alternative care models. Again, things that may seem rather intriguing, and you might say, well, we could never do any of this in Saskatchewan. You can do everything I've mentioned here in Saskatchewan easily. And then finally, we think about the different things that we can do to support people to stay to live as well as possible if they have to live in a long-term care home environment. And this is where we talk about the models of care, but then also important aspects of behavioral supports that can be helpful when people are living with dementia. So we know that long-term care is at a crossroads. And we know that right now we've got choices and options. That right now, that when you're actually waiting in hospital and waiting in a hospital to go elsewhere, it costs about $750 a day. When you think about long-term care costs, it's about $200 a day. When you think about home care for a long-term care equivalent person, it's about $103 a day. And when we look at Denmark, if you saw my recent escapades on CBC National and Marketplace about thinking about what things look like in Canada versus what we actually think about in places like Denmark. We know that Denmark actually, by having an appropriate strategy to think about long-term care services, they avoided building any new nursing home beds over 2 decades and actually saw the closure of thousands of hospital beds filled with ALC patients by strategically investing more in creating more home and community care services. And that's why I said that Denmark spends twice what we spend of its GDP on the provision of long-term care services, but it also spends the majority of its dollars on providing home and community care versus nursing home-based services. And we know that in Ontario, the government when I was helping the previous government in terms of its work on supporting older people to age in place, what they did was they started increasing the home and community care budget by at least 5% a year between 2011 to 2018. And that $1 billion plus in additional investments were able to significantly decrease or increase the number of people who were able to live in their own homes. But then with the subsequent government, we've actually seen decreases in the annual increases to the home and community care budget. And this government has doubled down on a commitment to build 30,000 new beds over a 10-year period. But this is the data from Ontario showing that our experiment worked. When we started making significant investments in our home and community care system, I want you to remember these blue bars represent the number of older people, 75 and older, living in Ontario nursing homes. The purple bars represent people 75 and older who are long-term care equivalent individuals who were able to keep in their own homes with home and community care services. And what you saw between 2011 and 2012 and 2016-17, so over a 5-year period, we were able to actually boost the number of people on that purple bar from 60 to over 90,000 people. So more people who are long-term care eligible are now living in their own homes and communities in Ontario than actually living in Ontario long-term care homes, showing that additional investment in more home and community care services was able to support more long-term care eligible to stay in their own homes as well. So what's in store for long-term care in Canada? Well, I say that a conversation needs to begin at the federal, provincial, and territorial levels to determine how we should approach the future provision of long-term care and how best to enable aging in the right place for Canadians. We also need to recall that while long neglected, the community support and home care sectors are more aligned than ever before with what older people want and will demand moving forward and require greater attention and investment. We also know that promoting aging well will be one of the best things we can do to help many people avoid the need for long-term care in future. And these are important things we need to think about. So finally, I want to just talk about a little example of systems change in action that just shows a little bit about the work that I've been doing in Ontario and sharing with my colleagues in Saskatchewan as well. So, again, when you think about Ontario and our hospitals and how they've been unprepared for an aging population, we know that it's been really challenging to best meet the needs of our aging population here. And so you can again say this similarly, that Saskatchewan hospitals are unprepared for an aging population. And so what we did at organizations at Mount Sinai Hospital, we decided to create what we call our advanced care, our advanced care, I have hiccups right now, our advanced care for elders strategy. What we did was we focused on redesigning or establishing new sustainable interprofessional team-based approaches that seek to enhance and improve upon current service models that span the care continuum. We also decided that it requires a shift in traditional thinking that currently underpins the administration and culture of most traditional care organizations. We also knew that it should not be adverse to identifying risk factors and the needs and intervening early to maintain independence, and that it also requires a relentless focus on monitoring and evaluating its processes and outcomes to support continuous quality improvement as well. And by taking this approach, what we're able to do is really build out a whole range of services by working in partnership with our community partners. I recall that about 5 or 6 years ago, maybe about 2015 or 16, I remember getting a call from the Star Phoenix in Saskatchewan, because they said, "Oh, it was written in in the throne speech in Saskatchewan that they're actually now going to be building a model of home-based care for seniors, following the model that you developed at Mount Sinai Hospital." And I was like, "Really? They put that in the throne speech?" And they said so. And so I got a call from the Star Phoenix saying, "Well, like, what is the Saskatchewan's planning to do?" And I said, "Well, this is fascinating. They haven't contacted me." And shortly after, shortly after I was called by the Star Phoenix, I got a call from the Premier's office of Saskatchewan saying, "Can we talk? We'd love to talk about your model." And I said, "Well, this is very curious, because it sounds like you've told people of Saskatchewan that you want to adopt my model, but you haven't called me, and I'm not sure how you're planning to do this." And then, anyways, started a whole call with your ministry and some of your geriatricians in Saskatchewan to kind of talk about what exactly has we done and what do we think could be done in Saskatchewan. But really, they were interested in a lot of our community-based models of care that really look at taking existing community assets and then re-engineering them in such a way that we can provide a whole range of community supports and services that can better support people to not have to come into hospital in the first place. But if they come to our emergency department, we have a number of models that we have in place to screen older people, to identify the issues and needs that they might have and the supports that they might require. And then also making sure that if they're admitted to our inpatient settings, we have the supports and services that we can provide them. And then finally, we have ways in which we can support them through our outpatient programs and supports to help them remain healthy and in the community longer. And sometimes these models allow us to avoid an ED or an inpatient admission, or allow different parts of the system to communicate together. And by putting in the effort and time to build these models that really build on a lot of good evidence from around the world and things that we've also developed ourselves, we've been able to show the results. Because by moving through into this approach, we've been able to significantly improve supports and services. So if you've been to Toronto lately, you'll see tons and tons of skyscrapers going up, 80+ story towers filled with people who are living in them. So our population downtown is increasing. And in fact, we have 53% more older patients we're supporting today than we were supporting, say, 5 years ago. But that's also in line. But also at the same time, if you come to my hospital's emergency department, you have the lowest chance of being admitted than in any emergency department in Toronto. The average rate at which people are admitted is about 1 in 3 people who come to an emergency department are admitted. And right now at our hospital, it's 1 in 4 older people are admitted to hospital, because we have all those community options to avoid an admission. But regardless, for those people who are admitted to our hospital, you have a 26% lower length of stay. Your readmission risk is about 14% lower. The chance of being catheterized or have a urinary catheter is about 50% lower. Falls decreased by 66%. And we've also decreased our pressure ulcer incidence by 93%. At the same time, our patient satisfaction rate is about 99%. And finally, we know that this is a model of care that actually can save money. So finally, just some pieces of advice around achieving systems change. First of all, identify your allies to build a coalition of the willing, and make the WIFM principle your secret weapon, which is what's in it for me. Often everybody can find an alignment in what they want to do. Older people want to stay in their own homes for as long as possible. That's great. That's what's in it for them. So then, and your colleagues in the hospitals don't want people to come to their hospital or want them to get out of the hospital as soon as possible. And community agencies want to try and keep people in their own homes, for as long as possible. So everybody's got, their own motivations, but often they can be easily aligned to really help. Then get together, meet and communicate early and communicate often with each other. I often say, don't let perfection be the enemy of the good. So make sure that you get people together, focused on what really can be supportive, and try things out and know that they might not be perfect. But again, by having that continuous quality improvement, you can always look at how you can further improve things as well. And then think big, but also start small. So, don't try and boil the ocean, but start with bite-sized things where you can start seeing some meaningful system change, and then celebrate every win. And you can achieve a lot without new money, but if you need it, you need a business case to demonstrate your value proposition. So what is it that you're doing, and why will it actually save money or deliver better value? And remember that you can't monitor what you don't measure. And so without data, it's hard to prove that you're making any meaningful difference. So again, think about the things that you can do on your journey towards enabling more system change. So I'm going to stop there, and I'm just going to say thank you very much for having me today as one of the speakers at your conference. And I think we have a few minutes where we can actually do some question and answer as well. So I'm going to pass it back. I'm going to stop sharing my screen, and I'm going to pass it back to Holly or other members of the team to maybe facilitate some questions and answers if they like.
Yes, thank you, Dr. Sinha. We are going to indeed take some questions now. If anybody has a question, we ask that you please enter it in the chat, and Linda is going to be monitoring that and keeping track of any questions that come up. One question, Dr. Sinha, is as a geriatrician, I believe you'd be able to comment on this. Why does care at home help people's physical and mental health? We know that it does, but why is that?
Yeah, so I think when you think about, kind of care at home, or why do people desire to live at home? Well, first of all, it's where people feel most comfortable, right? People often chose to live in that setting for a specific reason. They might have liked the neighborhood. They might have had friends and family close by, and regardless of that, why they ever moved there, we know that people develop a sense of community where they're at. It's a familiar place. You know where things are. You know what you like. You know what you like to do. You know what's in the neighborhood. All those sorts of things. So from a sense of personhood, from a sense of social and well-being, personal well-being, and being an engaged member of your community, that's one of the main reasons why people want to be in their own homes, and why it's good to allow people to stay in their own homes for as long as possible. We also know that as people might develop conditions like dementia, for example, being able to live in a familiar environment and setting is more likely to help you out, right? Some people can live very, very long and independent lives with dementia in their own homes because it's a very familiar surrounding. You know where everything is, you know where everything's located. Even if you become harder of hearing, harder of seeing, for example, or your memory isn't so good, for example, you're still living on rote memory, and you still know where things are, or what things look like, what things feel like. So it makes it easier to navigate, around your own house than in a strange and unfamiliar environment. And so these are the sorts of things that allow people to kind of stay healthier and well, and recover more easily, for example, the more we're allowing people to be able to stay in their own homes. But again, it's that idea about when you think about why people end up in hospital, often older, frail individuals will more likely end up in hospital when they have multiple chronic health issues, when they have physical limitations, but also most likely when they have poor economic and social supports, and something I call social frailty. You're going to have less social frailty when you're living in your own community, surrounded by people that you know, and in systems that you know how to navigate. So those are all some of the values of why it's healthy to stay at home home for as long as possible, or it works better for people to stay at home for as long as possible. But again, sometimes home isn't the best place for people. Sometimes people become quite isolated and lonely. There might be people, again, we met people in Denmark, for example, who said, I lived in a village where I grew up my entire life, but all of my friends and family predeceased me. I had nobody else. I was sitting in my own home. I was on my own. I was lonely. I was depressed. I had no community. And so this is where in Denmark, they created some communal apartment buildings that were intergenerational in nature that people could choose to live to. And this lady said, I love it, and you might have seen her interview on The National, but she said, why do I love it? Because she said, I've actually met people here from my own village, but I never really knew them. I mean, we grew up in the same village, but now they're my friends. And we have these things in common. For example, I live next door to a young family. They're more than happy to get my groceries. I have another family that has a baby. I'm happy to go over and babysit and all that. And so they can actually create a new home and a new community. So I don't want people to think that it's an either or situation. This is why we talk about aging in the right place as opposed to aging in place. Because again, we have to remember that we always have to figure out what is the right thing for people depending on where they're at, and that it shouldn't be an either or, and that not staying in one's own lifelong home, not being able to stay in one's own lifelong home is a failure of character, but sometimes it's a failure of our own systems to be able to provide people the support they need to age in place.
Yes. Another question. Do you have any recommendations for family caregivers?
And I don't know if they can be more specific about what sort of recommendations around what.
Didn't really say. I think what they're really thinking about is supports for family caregivers. So we've got people who are caregivers, members of the family, sometimes someone's partner is a caregiver. What are the ways we can support those people as part of a system to help support aging in the places we want to and should be aging?
Yeah, so I think ways to think about this are, when you actually look at what caregivers often need, family caregivers, there's kind of two broad areas of support. Number one is that when you look at the typical family caregiver, friend caregiver, they're often spending a lot of their own money to try and provide support for a loved one. It might be, just the gas money going to and from, the grocery store. It might be, their loved one or friend might not be able to pick up the groceries, so they just go and buy them themselves, and they say, oh, don't worry about that, I'll just cover it myself. But these things add up basically over time, and the average family caregiver spends about $3,500 of their own money on every given year in providing care and support to another person. So we have to recognize that there's a financial burden to being a caregiver. People might not consider it a burden, but it's a cost that we have to acknowledge. And so some of the things that we fought for over time is, how do we provide better financial supports for caregivers? And so one of the things that we did was we advocated for the creation of the new Canada Caregiver Credit back in 2017. And a lot of family caregivers are not aware of that. Now, one of the challenges is that you have to be earning a certain level of income or have a certain level of income to offset, the credit. But you can claim up to $7,000 as a tax credit for being a family caregiver. And if you're actually sharing these duties in providing care with somebody else, you can split the credit as well when you're the identified caregiver, care partner of an individual. So there are mechanisms, and there might be other financial supports that are available depending on which part of Canada people live in. But I think it's important that people are aware that there sometimes are disability tax credits, there are Canada caregiver credits, and sometimes some of the medical care costs that people incur might be eligible for a medical expenses credit. So there are various things that people should talk to their accountants about, especially if you're doing the taxes, your taxes, and or the taxes of another person. The other thing is understanding what are the supports that people can have. It's important to identify yourself as a caregiver. And then if you're caring for a person with dementia, for example, connect through with the Alzheimer's Society of Saskatchewan, for example. I think the Alzheimer's Society probably in Saskatchewan offers a program called First Link, which is often a way that caregivers, can often learn more about dementia, learn about what are the things that they should be anticipating or expecting. They might be able to get counseling and support to help say, how do I navigate long-term care, or are there supports and services available for me? Like how to navigate home and community care services, nursing home services, other services that might be helpful. Does the local Saskatchewan Alzheimer's Society offer adult day programs, whether you live in Regina or Saskatoon or Moose Jaw, wherever you are there services that are actually available that can basically give somebody a break, give them some respite and other supports, for example, as well? Are there other things that your organization or others have actually created to better connect caregivers as well? And sometimes it's just a matter of making sure that caregivers are also identifying themselves as such and reaching out to other family members and friends to see who else can support and fill in those gaps. Because when caregivers burn out, then it puts the person they're looking after at much higher risk of also not getting the support they need and therefore ending up in hospital.
Here's a big one. What do you think it would take to get a shift from spending on long-term care to spending more on social programming, like the Netherlands and Denmark? What is it? And I know you gave those 6 points that are some of that, but how do we get governments to shift their thinking? I mean, our current government is busy working on spending money on long-term care facilities. And some of that's important because some of those facilities need to be replaced and need to be upgraded and so on, and new facilities are needed. But it's hard to get that shift, and particularly to get that shift with a government who's in place for 4 to 5 years, and that tends to be the time frame that they look at, is the time up until the next election. How do you get that shift so we can get more of the focus like Denmark or the Netherlands?
Yeah, so honestly, it just takes political will, right? And again, right, and political will is often driven basically by what will get you reelected, right? So when you educate people more, so that they know actually we should be doing things differently. There are different ways of doing things, because ultimately, yes, government makes a decision, but who elects the government? Well, none of you, I don't vote in Saskatchewan elections, but all of you do. So what are you doing to educate your colleagues, share the information I shared with you? The way I advocate for that is doing things with CBC and the media. For example, I did an interview with your Star Phoenix paper the other day where they want to talk about the ALC issues and why aren't Saskatchewan hospitals doing things differently, and why is it the healthcare system? So there are ways in which you can advocate, big or small, but it's spreading the word, letting people know there's actually evidence to suggest that we should probably do things differently. And in fact, whether you're fiscal conservative, right, where you're thinking about, well, we need to save system money, but the older people will bankrupt us. Well, what I propose will save you money. Also, what we also know is it's just more dignified care. So regardless of whatever political stripe you're on, this is one of those rare policy paradigms that actually gets everybody what they want and actually is fiscally sustainable. So I think it's about, using your group to actually promote the work that, our NIA produces, for example, and spreading the word about our reports, letting people know about the things we've written about, because it's all laid out there. And certainly we know that, various governments with time start to adopt more of our models and principles. In fact, 2 of the 3 parties in this in the election that we're currently at in Ontario are proposing many of the things that we've actually come up with over time and we've been doing. So again, you can change it. And, remember that seniors vote, 80% of them do. And there's going to be more and more in Saskatchewan. So why don't we make ourselves busy educating at least our older voters to say to the governments, right, if you want to get reelected and you want my precious vote, this is what you need to do for me.
Saskatchewan has a very big geographic area, as does Ontario. I think perhaps we're a little bit different in that significant portion of our communities are very small communities. We're talking about communities of maybe 200, 300 people. And we've got many of those here in Saskatchewan. Any examples that you can give of other countries, other places that might have a similar geography and situation to what we have? Because you look at somewhere like Denmark and the Netherlands, and they're a really fairly small geographic area that they're doing this in, whereas we have a big challenge most places in Canada in terms of our geography, and particularly here in Saskatchewan.
Yeah, I mean, everyone likes to say, oh, well, Denmark's a small country. It's got only 6.5 million people. Like Saskatchewan's got 1 million, right? You know, Denmark's got 6.5 million. So, it's different sizes and different, and you can fit Denmark and Saskatchewan. So it doesn't you know what? Stop it. This is all silly nonsense. In the end, Denmark has rural and remote communities that are small. And the way they actually look at distance is fascinating. Denmark's one of the leading countries in the world for telemedicine technologies because it helps bridge their rural and urban divide. Think of that. I'm like, really?
Yeah.
You know, I could just drive 30 minutes and be there. But like people psychologically think of that as rural and remote in that way. Either way, there are small communities, there are big urban settings as well. But again, there are lots of different models, right? You know, so you're right. In a community of 200 to 300, does it make sense to build a 100-bed long-term care home? No, it doesn't, right? But maybe there's a model called the greenhouse model, for example, where you only need a few workers. For example, you build, you know, a home-like setting with rooms for 12 people, for example, where multiple people who might need care and support can live together, maybe an intergenerational household or not. There are lots of different ways in which you can do this. There are also cool models in the United States where they have something called elder foster care, where maybe it's not even building a building, but it's finding a family that lives in a community of 200 or 300 that might say, yeah, we're happy to let Mr. Smith come and live with us, right? You know, you don't have to, but we're happy to do that. Oh, and you'll give us, you know, $1,000 or $2,000 a month, you know, that help pay for his room and board. Yeah, happy to do that, right? He's from our community. He's a neighbor. You know, we appreciate that, you know, living on his own will be difficult, but if he wants to come and move in with us, you know, we're happy to do that. And thank you for helping to cover the cost, and we're willing to do some of this stuff. That's a very popular model that the Veterans Administration in the United States has created so that older veterans have an alternative to moving into a long-term care home, because there are lots of people who are like, I'm more than happy to bring someone into my house and do that. It's not for everybody, but it's about thinking about a variety of creative options. We have a strong adoption program for children, but there's no legal barriers to what we call adult foster care in Canada as well, or what they call elder foster care in the United States. So again, there are a variety of models, and we focus on all of them in our report. And again, you can say, yeah, that might actually be an idea that works for us. So again, there are lots of things that could be done. And again, it's not thinking about traditional models of long-term care that work in more larger settings. It's kind of looking at it from this perspective.
You mentioned telehealth. Do most telehealth systems, or do many telehealth systems, I guess, give the possibility of a person having a personal, consistent physician?
Sometimes they do, right? I mean, again, it depends on how you set things up. For example, we in Ontario, especially in our rural and remote communities, we have a model of care where we do remote patient monitoring using local community paramedics, right? Often our paramedics are often not busy for parts of the day because, again, there's not only so many major issues that can happen during a day. So they use the rest of their time in some communities where they're doing what we call remote monitoring. So certain people who need help with that, their data gets sent in. People feel secure knowing that their data, that they have their blood pressures, their heart rates, someone's keeping an eye on it. And then the paramedic will give them a call, check in, saying, hey, what's going on? If things are getting a little bit curious, they might actually come out and do a visit, for example, but they also liaise with the person's family doctor. So again, it's about leveraging existing resources that are out there. And so community paramedicine is a big model that we're now using in Ontario, BC, Alberta. I don't know about anything happening in Saskatchewan, but you've got got paramedics in all your communities. So are you leveraging them in this unique way that other provinces are doing? Again, all these answers exist out there. The question is, and that's sometimes a way to provide more consistency of care. And it may not be with a family doctor, but it could be with somebody else.
Do you have any comments on improving the education of healthcare students, doctors, registered nurses, LPNs, regarding geriatric
Yeah,
studies?
it's simply just do it, right? I mean, I don't understand again why we fund with our own public tax dollars all this education for people that doesn't include learning about caring for older people. It's ridiculous, right? So in Ontario, we have no medical schools that mandate geriatric training in them, but they all mandate pediatric training. So I joke, I've been advocating for a decade for Ontario medical schools to change and all Canadian medical schools to change. And I happen to be on the board of what was formerly known as Ryerson University. It's now known as Toronto Metropolitan. We just got approved for a new medical school, and guess what? One of its top 5 focuses is aging. Done. So I always joke and say, well, screw all of you. You're not going to change your med school curriculum. I'm creating my own. So at least we're going to create at least the first medical school that'll focus on aging right through at the beginning. Because, and again, when they actually went through, when the president of the university went and talked to people in the local community, he said, we didn't have to convince people about aging. He said they were demanding it, right? He said, we thought it was a good idea, and they reinforced that it was a good idea. So it boggles his mind why other medical schools haven't made aging a focus of their curriculums as well, because it's what our society actually needs. And that's what medical schools are supposed to be about. It's meeting societal need.
Someone is asking about the chart that you showed with the blue and purple bars. How do you define the long-term care equivalence that it talks about?
Say that again. How you define long-term care equivalency. So in Saskatchewan, everybody receiving government-funded home care, and I believe government-funded long-term care, is actually assessed using the same system called the Inter-Eye assessment system. So it's actually the backbone of how we assess and determine people's needs for home and community care, and also long-term care services. And so there's actually, by doing apples to apples comparisons, we actually have a made in Canada mechanism through that called MAPLE, or method for assigning priority levels, or it's known as MAPLE. And by doing that, it actually can say, it's like a 5-point scale, 1 to 4, and we say people who are 4s and 5s are really high needs individuals. Those are the types of people who we're identifying as people probably who benefit from being in a long-term care setting, for example, and 1s to 3s are people who could probably have their needs met adequately in the community. Well, so we've set a target in Ontario that well over 95% of our people in our long-term care homes should be Maples 4s and 5s. They shouldn't be 1s, 2s, and 3s. And right now, what I'm comparing are community recipients in that chart who are Maple 4s and 5s versus long-term care recipients 75 and older who are Maple 4s and 5s. And what we're seeing is we have way more Maple 4s and 5s in the community that are being supported the Maple 4s and 5s in long-term care setting. And in fact, actually, when you look at the budget, I think Ontario spends about $921 million providing care for those Maple 4s and 5s in the community, with on average about 3 hours of care a day, versus $2 or $3 billion caring for that a smaller number of people in long-term care homes who are receiving on average 2.7 hours of care a day. So again, it just shows you that you can actually provide people a lot more support in their own homes and communities for a lower cost as well.
Does your hospital have a process to connect seniors to care prior to visiting ER? So is there a process that connects seniors, I think, to keep them out of ER and having to go that route?
Yeah, so we have various things like community outreach teams. We have our local primary care providers know how to connect in with what we call our Cherry Hub now, so that we have a whole basket of services that we organize. We're linked in with our local community agency that has community social workers who can provide supports. We have our home and community care support system. We've got our home-based primary care supports. We've got a variety of different programs that we can connect people with, for example. And so primary care providers can flag those individuals to us. And by doing that, for example, we're often able to connect people with the right support so they don't actually, they can get those activated as soon as possible so that they don't actually end up having to come into the emergency department. So that's our ultimate goal, is that people don't fail and then end up in our home, but it's about having a much more robust community support. And we support about 200 people every month, new referrals to our outpatient supports and program in downtown Toronto. And again, we have a dedicated one single person who's kind of helping to route that person to the right service as soon as possible. And so it really has worked well in terms of better supporting people as well.
Question about your comments on your connection with the Premier's office. Can you elaborate any further on that contact with the Premier's office? Was there any further follow-up to that?
No, all they really did was, I think one of the chiefs of staff or whomever it was, this is years ago, called me up and said, "Oh, we want to come and meet you and talk about this and all this sort of stuff." And sure, I talked to them, and then I never really heard anything further. And I know my colleagues in Saskatchewan, one was a geriatrician, was involved in some planning, but I never knew really what came of it or where that money that they invested actually went, if it was useful, if it did anything further. But again, a lot of people talk a big talk, but it's actually, are they thinking thoughtfully about how to do things and how to look? So it's interesting.
Yeah.
Yeah, so I'll just recommend that for folks, what I'll do is I'm going to put it in the chat right now. Let me just do this. Let me go to this. Hold on. Okay, let's close that. Let's do that.
And just while you're doing that, I'm going to let people know that we are recording this session, and it will be up on our website sometime around before the end of the month. We're going to say that. So if people want to be able to go back and look at it again, they're certainly able to do that. So sorry, Dr. Sinha, I just wanted to mention that to folks.
Yeah, no, what I'm gonna do is I'm gonna put in the chat here. It's for your team and of interest here, I'm gonna put in the chat. So there's our website, nationalseniorstrategy.ca, where you can find more about the things that we've been advocating for. And if the Saskatchewan Seniors Mechanism wants to endorse this work, then there's a mechanism for they can officially endorse it, and we can get your logo eventually up there as well. And then so that's something for your group to consider. And then I'm going to give you a link as well to our reports that you can look at. So we have close to 30 plus reports here that you can look under that link. And that's where all the reports I'm referring to that have all the evidence, and it's all worked out there. And we make everything we do free and publicly available so that you can read all the latest evidence. We just published a report the other day that we did with EGAL Canada looking at the needs of LGBTQ older adults, for example, and their caregivers as it relates to dementia care. And we did that with funding through the Public Health Agency of Canada. So again, lots of different things that we work on. And again, all the evidence is there. We develop all that as well. And again, that might be stuff that that your team might want to better kind of promote and get out there, for example. And if any of you want to be on our mailing list as well, we send out a weekly newsletter, I think every Friday, where we show all the latest media reports, what's going on, what's happening. If you want to be tuned into kind of things at the national level, and you're all able to sign up for that, that's all free of charge. We don't charge for anything we do. So, and again, different ways to get involved and engaged overall.
So are you through that, folks there, you and others, available if we have questions and so on about how we can help move things forward here in Saskatchewan?
Yeah, I think the key is that yeah, I mean, again, I think the key is that we make everything, like, for those who follow along,
Yeah.
it's pretty
Yes.
straightforward.
Yeah.
We don't want to leave you helpless. I mean, I think the key is you guys are already organized as a group. You want to do it. I think the best way is to educate yourselves, figure it out, see what you like, and then a lot of people in their advocacy push forward our reports as they get meetings with various government officials. They're like, look at what our colleagues at the NIA have created and so on, and look at what they've done. So there's no mystery to what we're doing. It's just basically we're putting in a lot of time and effort looking at these issues at a national level. We try and focus on really good things that are happening across the country. And one of those things that you can actually look at support as well. We'll get jumped up, prepare. Center Mall's iPhone to try and mute themselves here as well. That's perfect. Thank you. Perfect. So yeah, so again, we yes, Beth, I think we got them to mute, so we're all good. Okay, I think that's basically it for me.
Okay.
I want to be mindful of your time and make sure that you got that time for the break that you're planning.
Yes.
But I really appreciate everybody's thoughtful questions and interest. And again, if you are interested, please do take a look at our NIA website, and certainly if there are things that you want to, I'll just make sure that you have our yeah, if you ever want to get involved, just simply, it's easy to make contact with us as well.
Great. And I want to say a big thank you to you, Dr. Sinha, for taking time out of your day and for all of the excellent thoughts that you've shared and that you keep sharing. We hear you in media and so on, and we were so pleased that you were able to join us today. So thank you very, very much.
No, my pleasure. Thank you, everyone, and have a great day.
Thank you.